Okay. Well, I think we can get started. This. So if you want to take a moment and just mute your microphones if you haven't already, that would be lovely. We're just letting a few more in here. Okay, perfect. Can everybody see my screen okay?
Yes.
Great, okay. Well, good evening, everybody. My name is Julia Alton, Executive Director of the Canadian Fabry Association, and thank you for taking the time to join us tonight. We have a very important conversation to have and a great presentation with some great speakers. So tonight we're talking about Fabry and females, and it's supported by Amicus Therapeutics. As you can probably see, the Zoom meeting is being recorded. And so this way, I mean, it offers the opportunity for people who weren't able to join live tonight to watch it. And also, if you are listening and you want to just hear a little bit of a part that you kind of missed a little bit, or you want more, you can always go to our website, and it's going to be listed under our webinars. So great opportunity to just kind of watch some parts back. Um, for questions, we welcome any of your questions. Put them in the chat, and I think we're probably all Zoom experts by now, but just for a refresh, there's a chat at the bottom of your screen. You can always just type it in there, and at the end, we will go through them and do our best to get all your questions answered. So, like I said, it's Fabry and females, and I'm holding up this book here, if you can all see it. Hopefully, ooh, maybe you can kind of see part of it because of my background. Um, so this is I'm showing you a little book that was put together with a few authors. I was one of the authors, as well as Fabry International Network, as well as Amicus Therapeutics. And I'm just going to open up today's webinar with one of our quotes from Mary. And Mary is the president of the Fabry International Network organization. And so this book is called Dismissed, Unheard, and Unseen. And I actually just want to open up my screen again, just as a show of hands. As the women in this chat, have you felt at any point dismissed, unheard, or unseen? If we can see your videos. We welcome your videos on, by the way. It's so nice to see everybody's face. Yeah, got some thumbs up, hands up. Yeah, yeah, exactly. Exactly. And this is why we're having this conversation. So in the introduction, I'm just going to read a small section to you. So it's for many women, the story is similar. You've had symptoms for as long as you can remember, chronic pain, overwhelming fatigue, strange sensations, and you finally seek help only to be told maybe it's in your head. It could be your hormones. You must be going through menopause. And these responses are not only dismissive, but they can actually be dangerous. This isn't unusual, unfortunately. It's the reality for many females living with Fabry disease. And often we as women assume our symptoms are caused by stress, aging, or life changes. Fabry disease in females has long been misunderstood, just like all of us just raised our hands. It's been misdiagnosed and it's been ignored. And the result, women and girls sometimes are left feeling dismissed, unseen, and unheard, without answers. But we are here to change that. So this is a white paper, and you can find the full white paper on our website under resources, and you go to medical. So if you want to read, read this whole white paper, that's where you can find it. So that's what we're talking about today. Um, why this conversation matters. So this conversation matters to me because I live with Fabry disease. I am a female, and when I was 16 is when I was actually officially diagnosed with Fabry. Up until that point, I was always told that I was a carrier. So I was told I was a carrier until you have symptoms. And once I had symptoms, then they said, okay, so now you have Fabry. Thankfully, today we know that this is a different story, and we are here to tell you a lot more about Fabry and females. So This is why this conversation is so important to me. And I'm so glad that you guys are all on the call to learn and get educated and feel more empowered by what you hear today. And on the call with me, we have Dr. Bechet, Rebecca, and Sheila from the Magic Clinic. So, Dr. Bechet, I'd like to hand it over to you first and tell everybody a little bit about yourself and also why this conversation matters to you.
Thank you. Thank you, Julia. It's a pleasure to be with the group. I'm working in Montreal and I've been, I'm sorry, I did not push that. Just a second. Okay, good. So I'm in Montreal and I've been responsible for the Fabry Clinic. I am a nephrologist and together with my team, you have seen Carole Fortier, we have been responsible for all the patients in Quebec, a total of 132 patients. And together with Sherbrooke and also Quebec City, we see all these types of patients, every 6 months to every year in an X-linked disease because the gene responsible for the disease is on the X chromosome. There are two-thirds of patients that should be women and one-third that should be men. This is a law, a genetic law. And so that in this X-linked disease, like in other X-linked disease, it is very important to consider women as uh, uh, carrying a disease. That means not carrier only, but also they could be affected with severe renal failure, with severe uh, heart failure, and I will describe that. So if I could have the next slide, please. So history of dismissing Fabry disease in women, in female patients. Well, as Julia mentioned, she was a carrier and then she was officially recognized as a patient. And we should do that so that, as you know, women have two X chromosome, one coming from the father, was one coming from the mother. Julia told you that she's affected. Father was affected. So she was an obligatory carrier. And in the schematic representation on the right, you can see those two X chromosome, and you can see that in any cell, these two X chromosome are not expressed at the same time. So there is one X chromosome that will be expressed and the other that will not be expressed. And this is random. That means that either the X chromosome from the father was affected, will be represented, will be expressed, and then this will mean some kind of disease. And this randomization, this differential expression is different from organ to organ and so that also it could change, and so that throughout a woman's life, there could be some variation in the expression. So let's say that you do some kind of clinical examination, including heart examination, echocardiogram, in a female patient with Fabry disease, and you find very little type of symptoms and signs when she's at 50 years of age, but this will not mean that by age 60, she could have some deleterious type of manifestations, that is atrial fibrillation, that is heart failure, and that is the necessity also to install some kind of pacemaker. So phenotype manifestations are nuanced and unpredictable in female patients, and so that you should examine organ by organ, and you should consider there could be some variability and that you should consider that these signs and symptoms may appear later in life. And in our clinic, for example, at Sacré-Cœur, we are extremely careful to examine regularly, at least once a year, often every 6 months, women with Fabry disease and to look for signs of deteriorations to fulfill the criteria for treatment in the Canadian Fabry Disease Initiative. So this is, you see these women here, they are mosaic. That means that in every different cells, so this disease X chromosome, we call it allele, might be expressed and might give signs and symptoms. So that some female patients will have acroparesthesia early in life, and some others will not. Some female patients will have renal failure by age 22. This is really rare. We have a patient in Montreal that a biopsy, a kidney biopsy, to be sure that the proteinuria, I will describe the kidney manifestations later, was really due to Fabry disease. And indeed, it was only Fabry disease. She's doing well. She has been transplanted after dialysis, and she has two normal boys, so that she transmitted only the X chromosome that was not bearing the mutation. Next slide, please. So the family tree, obviously, you are used to reconstruct family trees. It's extremely important. You know that there is no male to male transmission in Fabry disease. That means if you are a male, you have a disease X chromosome, but in order to have a son, so that you will use the X chromosome of your wife. And if your wife is not affected, then the boy will not be affected. So there is no male to male transmission. And in certain family, you can choose to have only males if you are a male subject with Fabry disease. So that, the affected father, he will have obligatory carriers, because when he's manufacturing beautiful girls, so obviously each of these girls will have an X chromosome from the father. They would be obligatory carriers as compared to a non-affected mother. And this non-affected mother obviously will have all the descendants to be completely normal. So those types of family tree, and you know how to exclude X-linked disease. If there is father to son transmission, there is no Fabry disease. Next slide, please. So not less affected, just differently affected. And so that somebody should continue, and I will come back to the kidney manifestations after. So,
Thank you. Thank you,
yes.
Dr. Bisset and Julia. I'm Sheila, and this is Rebecca, and we've had the privilege of working in the Fabry community for the last 10 years almost now with Dr. Neil Connaught of Metabolics and Genetics in Calgary. So thank you for letting us be with you today. And so I love this slide. Mary Pavlo, president of Fabry International Network. I'm going to read what she wrote, because she wrote, "We need to stop comparing male versus female and look at the individual, seeking care tailored to one's needs, not by gender." And just really stating that we need to look at the unique person and stop using males as a benchmark to initiate treatment, because females can truly experience full disease manifestations. So looking at a person-centered understanding instead of gender-specific. Next slide, please. So this slide just looks at the disease progression of Fabry disease in both males and females. We know that substrate in the cells can start collecting before a baby is even born. And it starts with low burden, stage 1, with some deposits, and it can move to some cellular injury, can cause tissue inflammation, some scarring, and then the last stage being potential organ failure. Next slide.
So we're not going to give you a whole rundown on what is Fabry, because if you have been connected with the amazing CFA for any length of time, there's so many opportunities to learn about the disease. But we are just going to give a bit of an overview of what happens in the body and how women can be more affected than males or differently affected than males. So some symptoms to pay attention to. So just a very fast overview. In your cell, or in your body, sorry, there's millions of cells called lysosomes. And our lysosomes are these recycling centers of the cell. They're the blue cart. If you live in suburbia in Canada, like we do, you might have a blue cart for your recycling. So that's your lysosome. And the AGAL enzyme is one of those enzymes in the lysosome that's responsible for breaking down that recycling or this fatty substance that builds up. So we are going to call that GB3 or GL3. It's the biomarker, the substrate. It's got lots of different names that people refer to, but that AGAL enzyme is like the truck. And the buildup of storage is the garbage or the recycling that's building up is that GB3. So with Fabry disease, there are not enough trucks. In some cases, there's no trucks on the road that are going out to take the recycling out of those recycling centers. So that garbage or the recycling builds up inside your cells. Next slide there, Julia. So what does this mean in the body? GB3, the substrate, can build up and cause the blood vessels to be narrowed. So this can cause issues in your kidney, in your heart, and in your brain. It can restrict the blood flow and cause them not to work properly. Next slide, Julia. So auditory, go back one. There we go. Thank you. We'll just go a quick systems assessment. So if you start with your ears, one concern that many patients with Fabry disease comment is that they have ringing in their ears. They have hearing loss because the buildup of the GB3 is causing some constriction in the ears. If you go to the next one here, Julia, we just have a quick picture of the ear. So in that canal, so tinnitus or tinnitus, depending who you're talking to, potato, is that ringing in the ears because the hearing is broken down. So there's little hairs within your ears, little cochlea that rub together. And when your hearing is impacted, what you're hearing is those little hairs, those little cochlea rubbing together. So they're bending or they're breaking. In typical non-Fabry patients, we would expect 15 to 20% of the population to experience the same kind of tinnitus by about age 60. But in Fabry disease populations, according to the Fabry Outcome Survey, so these are those surveys you all fill out because it does tell us something, and that's why we want you to keep doing them. But the Fabry Outcome Survey tells us that this number goes up to about 75% in patients, in female patients, by age 60 of that hearing loss, of that tinnitus, compared to about 65% in males of the same age. So this does affect you. It may require hearing aids, and hearing aids now are getting very tiny and very slick and very useful. So that's something that may affect women more than men, differently than men.
So yeah, so then we're going to look next at the heart. So some other symptoms that many on the phone call might understand here today is some angina or chest pain, fatigue, feeling like they just can't handle a lot of exercise or a lot of movement, and hot hands or feet. And we'll just take a look at the next slide because it gives us a really good picture of what can happen in the heart. So the left ventricle actually has a really big job to do. It pumps blood to the whole body, whereas the right ventricle really focuses on the lungs. So when that GB3 builds up in the heart, it can actually cause some stress on those walls. And I don't know if I can point. Can you see my pointer? The wall there can become thickened, which is called left ventricular hypertrophy, which you might hear us talk about in clinic. So that thickening has kind of a cascade of events, and we'll go to the next slide. So when that wall gets thickened, it can actually increase your blood pressure, can cause scarring, and can cause just a change on how your heart actually pumps and functions. Sometimes you might hear us use the word ventricular fibrillation, or you might hear us use the word arrhythmias. So changes in the electrical activity of your heart and how it's pumping, and also the thickening causes your heart not to pump as well. So over time, there's a picture there showing a normal wall. You see the purple outline around the yellow. And then over time, that wall can become thickened, causing a change to that pumping mechanism, which in the end means your heart might not be able to pump as much blood out, the ejection fraction at each beat. So when people tell you that women don't need to be monitored for heart symptoms, I'd like you to challenge that because female carriers are just as likely to have fibrosis and left ventricular hypertrophy as males. And sometimes females, evidence shows that fibrosis can actually happen before the thickening of the heart. So the scarring can happen before the thickening of the heart. So we'll go to the next slide. And this just shows you that, yeah, left ventricular hypertrophy, or that thickening of the heart walls, happens in females as well as males, 46% in males, 28% in females. And cardiac symptoms are actually pretty equal in comparison for reporting it, 69 in males and 65 in females. So I do want to stress that when you're sitting at your doctor's office and you're talking about getting some heart investigations, it's really important to ask those questions. Should I be getting an MRI? Should I be getting an echo? How about even just an ECG? And then saying to your healthcare provider, challenging them and saying, what will this test tell me about my health? What's it going to show me about my heart? And also, if you've had this test in the past, did my testing show any different outcomes? What changes have I had since the last time I had this test completed? So I would challenge you just to ask those questions at your visits. Next slide.
This is the kidney. So this is where we throw this back to Dr. Bichet, who loves the kidney, to tell us how kidneys function in males versus females, and what should these women be watching for and asking for in clinic.
Exactly. So let's talk about the kidneys. So next slide, please. So you will see that the function of the kidneys. In each kidney, there is around 1 million glomeruli. So 2 million glomeruli, in every individual, male or female. So they filter the blood and they produce urine, and the filter is extremely important. So the filtering is to make sure that there will be no protein in the urine, because the filter is extremely selective, so that if it is working well, there will be no protein in the urine. On the contrary, or by contrast, you know that Fabry patients, males or females, are having sometimes large amounts of protein in the urine. We assess that with a 24-hour urine collection. And in fact, the filter is made of three things: the basal membrane, and on the interior of the basal membrane are endothelial cells, and on the exterior, that is on the epithelial part, are podocytes. So podocytes, that means that there are many feet with some kind of interdigits. And these podocytes are full of deposits, GB3 deposits, very early in life of males and female patients with Fabry disease. And we call them zebra bodies. And so that they are characteristics of Fabry disease electron microscopy. And these deposits makes the filter unable to properly block the protein passage through the kidneys, through the glomeruli, hence some kind of accumulation of protein in the urine. And so that we check every 6 months or every year in male and female patients the amount of protein in their urine. And we should never allow the amount of protein to go beyond 300 milligrams per 24 hours. That means that we have been missing an early possibility to treat those patients. And like in cardiac disease, or like in kidney disease, or like for acroparesthesia, there is very much importance of early type of treatment. So the second bullet here says that podocytes are visceral epithelial cells, highly specialized for the filtration. And in Fabry disease, they accumulate the GL3 and GB3 responsible for these types of picture zebra bodies. Next slide, please. So here is further development of proteinuria, a sensitive biomarker of Fabry nephropathy. So that if you have a patient with Fabry disease, seen early in life, there will be no proteinuria. But progressively, there's a possibility to see proteinuria again according to that differential expression in males and female patients. Here in this slide on the left, Proteinuria is found in 10% of children under 18. Male patients, when you look at their placenta, so it's the placenta is the same genetic component as the boy or the girl. There are already deposits in the placenta of those GB3 and already deposits in the kidneys per se. And as you can see here, by age 35, proteinuria is present in about 50% of male patients with Fabry disease. If you treat them early, then there will be no or considerable delay in the apparition of proteinuria. You will maintain the filter. On the right part of your slide, we can also measure the amount of these podocytes. When these podocytes are full of deposits, they are shed in the urine. That means you are losing those great cells that are doing the filtering business. So Fabry patients have been shown to have high levels of podocyturia, that means these special cells in urine compared with the normal population. Also, early in life, in both male and female patients, there's hyperfiltration, as if the non-affected glomeruli were trying to compensate for these glomeruli that are full of deposits. So hyperfiltration, and also you can have some kind of specific measurements. You can measure plasma creatinine to determine if there is renal failure, or you can measure cystatin C, which is a better measure in any type of renal disease. So that is sensitive to change in GFR, glomerular filtration rate, in early phases. And again, very important to pick up that early in males and female, and to treat early in males and females. Next slide, please. So another picture of the glomerulus, with an efferent arteriole. So they're feeding the glomerulus and then, filtering these types of podocytes with those many types of feet that are with interdigitation, and then the efferent arteriole and the rest of the nephron. That means not only the glomerulus, but also the tubules and the possibility to reabsorb, sodium and water. And as you know, we are filtering 180 liters, 180 liters of plasma per day. And we are excreting only, let's say 2 liters of urine per day. Next slide, please. So the multisystemic signs and symptoms are most probably for Sheila and Rebecca. And so that I will give you the continuation of the speech. Thank you.
Well, you can certainly add to this as well, Dr. Boucher. So just some of the things that we see in the neurological element, so brain fog, fatigue. We know that strokes and whether that ischemic or hemorrhagic strokes can be an event in Fabry disease. So we do want to be watching. These are the things that we can't always see that are happening behind the scenes. And next slide, we just talk about cerebrovascular. So it refers to the blood vessels that are impacted by Fabry disease. These are the small blood vessels, the arteries and veins that supply blood to the brain. Sometimes that substrate can build up in those vessels and they can cause symptoms like dizziness, brain fog, just some cognitive changes and whatnot. So I'll just go to the next slide real quick and I'll show you a picture of an MRI and kind of what those white matter lesions look like. Some of these we might see in some older Fabry patients. Sometimes it does happen midlife as well, though, in our clinic, certainly. But you can see those white matter spots there. That's an indication of just Fabry disease progression. Dr. Boucher, do you have anything to add about that one?
Yes, indeed. So that you could imagine that the small vessels in the brain have been obstructed by deposits of GL3. And this is challenging because the enzyme replacement therapy are not passing through the blood-brain barrier. And so that you can imagine that maybe small vessels will not have access to a high concentration of circulating enzymes, so that there are a lot of things that are unknown and untreated. Also, and specific to women with Fabry disease, it seems that there are more women affected with strokes at an earlier age, by 40 or 50, and this is a concern. There is some unpublished data stating that if you treat early, again, male or female patients with Fabry disease with enzyme replacement therapy, there is no data so far concerning the migalastat, but if you treat early these patients, they will have a lesser incidence of strokes. So that this is very important, to document and to know exactly the pathology and to look forward for other type of mechanisms and also treatment. Should we add, for example, aspirin, acetyl salicylic acid, systematically after a stroke episode to these types of patients? We are used to do some multi-type of specialty clinics with neurologists and cardiologists. So this is helpful. Hopefully, it's not so frequent. Let's say less than 20% of our patients. Yes.
Thank you. That's a really good point.
Yeah, so it's my turn now. I just want to add to what Dr. Bichet said. When we think about the neurological system too, we as women downplay our symptoms. I don't have Fabry disease, I have other things, and we are quick to say, oh, I'm tired, oh, I'm stressed, oh, it must be ... And Julia started at the beginning. It must be menopause, it must be the weather changes. But if you are experiencing that brain fog, those symptoms of stroke, TIAs, if you're not getting words out the way you used to, it is important to pay attention to that, because these are symptoms that can be treated, and we don't want to just write them off as something else. So encouraging you to advocate for yourself is part of that.
I can also add that sometimes it's not you that will notice these symptoms. Sometimes it's the people in your life. And so we've certainly had people come to clinic and visit us and say it's, it might be their spouse or their children or other people that might take notice of some changes to their routine or just the way they're processing their thoughts. So it's really important for the whole family, the whole support system to take awareness to this.
Okay, a couple more symptoms or systems that are affected, and then we're going to circle back to why this is so important. In your eyes, if you go to the next slide there, Julia, some of our patients have come to us through the optometrist or the ophthalmologist. So women are more likely to have these eye findings than men. They're nothing that will bother you. This corneal verticillata, it's a lacy appearance at the back of your eye. You can't see it, but this might be one way that patients may be diagnosed. So as those blood vessels in the eyes can narrow because of that recycling that's piling up, the trucks are on strike, the buildup is there, the blood vessels narrow, sometimes it can lead to cataracts. Cataracts happen without Fabry disease, of course, but it could be related to your Fabry disease. So it is something for you to follow with your eye doctor on a regular basis. Next slide there, Julia. And then your hands. Right at the beginning, Dr. Bichet talked about the acroparesthesia. We know that this is more common in younger men, but that does not mean in classical males Fabry, but it doesn't mean that women aren't affected. So when we come to clinic, or when you come to our clinic, Dr. Khan will do a hot and cold test and get you to close your eyes and see how your nerves in your hands and your feet are responding. We want to look for those little red dots on your hands, the angiokeratomas. Are they changing? Are they increasing in frequency? These are signs that we want to pay attention to.
Okay, next slide. So we're also going to look at your stomach, your GI symptoms. Now for women, this is greatly reported. Actually, more women report GI symptoms than men. And just the next slide there, we hear often about abdominal pain. A third of the patients are abdominal pain, followed by diarrhea and then constipation. And that GB3, or that buildup, the junk in the cells, builds up there in the endothelial wall and can lead to vessel wall expansion. And so when these cells, the cascade changes, they start dividing, and it can lead to some thickening of that wall and decrease the blood flow to the area. So we see all sorts of symptoms in relation to this, and it does impact your quality of life, of course, and at every mealtime. So some people have said, yeah, sometimes it's good to eat smaller portions. They're easier to digest, drink lots of water, maybe limiting your fatty or your fried food. And I was going to throw Dr. Boucher in again and say, did you have any suggestions for how to deal with some of these GI symptoms that you see in your clinic?
Well, these are very important. And for example, if you question your patients, they would tell you that these symptoms are appearing 3 days a week. Which is extremely important. And sometimes they are sensitive to milk or milk component in their food, so that some patients have a better quality of gastrointestinal symptoms. That means less symptoms if they restrict milk or cream, and so that sometimes this is helpful. Also, if you introduced some treatment, being enzyme or being chaperone therapy, there will be a delay, but most of them, and it has been well demonstrated, will improve with treatment. So there's a benefit of early treatment there too. This is quite annoying. These patients, it's rare that they have some excess weight, and we think that maybe it's because of this gastrointestinal type of symptoms that limit some way the quantity of food that they are able to absorb. And this is really painful and varies from patients to patients, but we have to be careful. And we must not dismiss these. We have to listen and to make some comparison from one visit to another. And this will be appreciated by the patients. Yes.
So just Amy from the chat here just said, when you say start treatment early, what age range are you referring to?
Yeah, so in the Canadian Fabry Disease Initiative, any patients fulfilling the criteria, being renal criteria, cardiac criteria, pain criteria, will be allowed to start therapy by age 18. If there are some very severe symptoms, for example, gastrointestinal symptoms that we spoke about, we have at least 2 young patients in Montreal with severe symptoms that have been presented to the Canadian Fabry Disease Initiative panel, and I've been allowed to start treatment so that, if you need an intravenous treatment, let's say, you can start by age 10. You have to infuse, obviously, every 2 weeks. If you have the benefit to have an amenable mutation, that means you can take an oral chaperone therapy. So I think depending on the signs and symptoms, you can start early on. After 10 or 12 years of age, obviously, you have to consult to discuss with the patient, even with the young patient and the parents, obviously. So there are some good data in the literature treating adolescent patients with Fabry disease and bearing severe mutation that we call classical mutations. And these experiments were done in male patients with no acroparesthesia, with normal glomerular filtration rate, with normal cardiac function, had some kidney biopsies. They were found to have deposits in their kidneys. They were treated for 5 years with enzyme replacement therapy. Galafold was not available at that time. So these patients were 17, 18 years of age. And now the study was finished after 5 years. And we are still following these patients 15 years later, and they are doing extremely well. So that and we had some recent discussion with Michael West. And so more and more concerning male patients, we would like to treat them very early on, by age 18. But again, if we follow women with, with some kind of astute type of repeated measurements, we can treat them also early. And, as early as these symptoms and signs are severe and perturbing life. Yes.
Thank you. Next slide.
No, this slide is good. We should discuss that.
Yes, sorry.
Oh,
Here we are.
no. We're going to go to the next one, though, because we like it better.
Oh, okay, that's
Yes,
fine.
because for the sake of time, we
Oh,
are
it's
talking
my
about
fault.
all the symptoms you probably may experience in your course of Fabry disease, but we just like this slide because it shows us one sure thing that we all know is that we are all going to die. But that doesn't mean that you are going to die early. Dr. Khan always has a phrase that in the Magic Clinic, our goal or his goal is that you will die from something other than your Fabry disease. Because unfortunately, as humans, we still may get cancer. We still may get other diseases and accidents and things like that. We just like that this slide shows that females with Fabry disease, while you may have symptoms, you may feel dismissed, unseen, unheard. You aren't. You aren't dismissed. You aren't unseen. You aren't unheard. So we just want you to be aware of what your symptoms are because, next slide, Julia. This is a take-home message that Sheila is going to tell you in the next slide.
Why are regular appointments with healthcare providers necessary? Because we do really want to capture your life events. We are here to listen and we like you. We want to see you every 6 months or at least touch base by phone every 6 months. We cannot capture the changes that you're speaking about unless we talk to you frequently, and that's so important. We want to have those touch points, whether it's by phone or in person, so that we can capture the changes that are occurring, the changes you can see, which is the next slide. So some of the symptoms you can see, we can capture those just by you kind of speaking to us and relaying it. So whether that's racing heartbeats, I'm having chest palpitations, I'm having GI pain and discomfort, I'm feeling tired. And as I've heard some patients describe tired as it's heavy to move, I'm having that kind of tired. We want to hear the things that you can feel. And then the next slide, we also want to talk about the things you can't feel. So what we talked about in the left ventricular hypertrophy, the thickening of the heart, or the proteinuria building up from your 24-hour urine test. We want to look at those symptoms and see if we can have any intervention to help you with those. I want you to be able to come into a clinic visit and let us know, ask yourself some questions. Have certain activities become more difficult? Let us know if you have new or worsening symptoms. Or let us know when you felt a difference in your routine. What changed? What was going on in your world that changed? We do care and we do want to hear about these things. It does help us treat you with a tailored treatment style. Next slide. We'll let Dr. Bichet speak on
This
this
one's
one.
yours, Dr. Bichet.
Okay, so that timely treatment initiation is associated with lower rates of Fabry-associated clinical events. Yes, it's very important, the clinical events, so that at some point, if you have some doubling of your serum creatinine, that means, for example, that you decrease your kidney function by half, this is an event. If you have a myocardial infarction, if you have a start of atrial fibrillation, if you have some signs and symptoms of cardiac failure, so this is a clinical event. And so that if you do these types of treatments, you are going to have less of these renal, cardiac, neurological events. And patients with in the left, patients with a history of FACE, so Fabry-associated clinical events, before ERT initiations, were more likely to develop new phases after initiating treatment, yes, than those without prior Fabry associated clinical events. So we have to account that as if, it takes about 6 months to have some beneficial effect. So, and in patients who had a cerebrovascular phase before ERT initiation, the risk of developing another was tripled. That means that Fabry disease is not only some kind of alpha-galactosidase deficiency, enzyme deficiency, but also you have to take account of the entire patient and of the entire genetic of this patient. And if this patient is smoking, if this patient is obese, so that, is more at risk to have these types of events. In the middle panel, lower EGFR, lower filtration rate, is associated with an increased risk of Fabry associated clinical events in patients with Fabry disease. Hence, the necessity to measure frequently and early on the glomerular filtration rate and also the proteinuria, and to judge about, I told you about this limit, 300 milligrams of protein per 24 hours. We should always never reach that, because we should see our patients early and treat them early. Timely treatment initiation and renal function preservation may reduce the risk of not only renal events, but other clinical events. So a retrospective study found that for every 10 cc's per minute reduction in baseline eGFR, this is important, 10% of renal function, the risk of developing other clinical events increased by 20%. So the kidney is a reflection of the general well-being of Fabry patients. And finally, on your right side, strokes are 12 times more common in patients with Fabry disease compared with the general population. This is somewhat interesting because even some neurologists have looked at all their strokes, for example, that they see within a year. And so that it's rare to see Fabry patients, undiagnosed Fabry patients in this population seen by neurologists. But you should be careful. So these strokes occur at a younger age in untreated Fabry patients. And risk of stroke, 64%, lower in patients treated with agalsidase beta, Fabrazyme, versus untreated patients. There's a paper that is in press concerning that. No stroke events were reported during nearly 4 years of follow-up in the megalostat treated cohort in patients obviously bearing those types of minimal mutations. And this is quite interesting because megalostat is not restricted by some barrier. It penetrates the brain, it penetrates better the vessels. It might be the explanation why no stroke events have been observed here. So, this is very useful for male and female patients. And again, in the Canadian Fabry Disease Initiative, we have almost 2 times more women with the disease. That means that we are trying to reconstruct family trees and to see and treat all the women in Canada, and we are proud of that.
Thank you, Dr.
Because
Boucher. Oh, sorry, Sheila and Rebecca, go ahead.
go right ahead, Julia. It's all good. Go for it.
Well, I was going to thank everybody for hanging with us this far. Great presentation so far. And thank you to all of you because I think the message that everyone I hope is hearing is that we want to know what you're experiencing. Dr. Boucher said it's important. We must not dismiss. We have to listen. So that's our Fabry physician telling us that he wants to know. I heard that Sheila explained to us, you have to share because they can't help us if we're not sharing, if we're not telling our symptoms. And when she was saying that, it made me think of something. We recently the CFA did a survey in January, and I think there's a lot of people here that were participants of that. So thank you for that. It's really important when you take the time to do that. It means a lot to us. And something that I learned from that survey was 80% of patients had said they don't want to go and tell their physicians all of what they're experiencing and their healthcare teams. And the top 3 reasons were because they were worried that they were going to sound like they were complaining, they were scared, and were fearful of sounding like they were too much. And I think that we're all here to tell you that you're not too much. And what you're going through for all of us, for what everyone is going through when you live with Fabry is a lot. And everyone's here to listen to that because we want the best outcome for you. And I think that it's really important to, if you're worried about those things, shift your thoughts to a partnership. You and your team, you're a partner, so they can only help you with what you bring forward. Something really important to me that I learned maybe a few years ago was we don't always know what's going on. Some of our symptoms are silent. And this really spoke to me because I'm thinking, well, if I'm feeling okay or not feeling okay, that's what I'll share. But here are some questions to take charge of your care. So they've been up for a little bit. Um, Sheila said something though in this, and it was, well, should I be getting an MRI? Should I be getting an echo? What changes have I had since my last echo? What changes are happening? And sometimes we get really busy, right? We're all busy. Sometimes we're a little nervous in clinic, but those keeping some of these questions or writing them down, really important because when you get in there, it feels different than when you're maybe walking in or in the waiting room. If you have it, what changes have I had since last time? Great question to ask. I really like what signs or symptoms should prompt me to contact you sooner because sometimes we wait that whole year, but maybe we don't need to wait that long and we can just call at 6 months, or, is there a specific sign or symptom that I might want to call? So great questions.
This is just our last slide. Part of why we do this and why we want to promote community here is because it's so important to find your people. So we were made for community. Study after study shows that loneliness increases drastically. It causes grief and depression without a close community. So you have your Fabry community, your healthcare community, whether it's your work or your school or your sports team or your church, whatever your group is, it's really important to use your brave voice and to say, I need a friend, and that's okay. I need somebody in my court because I'm gonna I'm going to make up a stat that 9 times out of 10, that other person is going to say, me too. So be brave, find your people, find your community. And thank you to Julia for what you do with the CFA, because her and Donna are so instrumental in helping build this community for you. So please always reach out if you have questions.
Yes. Yeah. And challenge us at your clinic appointment. Say like, hey, you want me to go for a 24-hour urine test? What are you looking for? That's okay to ask us questions too. And it gives you some power and knowledge to know why we're doing what we're doing and to take ownership of your care and these assessments that we ask you. And just know that your concerns are equal and they're valid and they're real and they deserve some care and attention. And we are here to listen and we want to hear from you. So please, please come to your visits and share with us.
Thank you. Let's do a round of applause if we are on our videos. Yeah, very good presentation. Thank you. You guys are all an incredible team. We'd like to open it up for some questions because I'm sure we may have some. And here we go. We got some thank yous. Well, thank you for being here.
Thank
There
you
was
for
a question.
the presentation.
There was a question concerning the early treatment.
Mhm.
So that at Sacré-Cœur, we work in close collaboration with the pediatric unit. There are physicians there that are metabolic physicians that know very well Fabry disease. And again, we have seen at least 2 girls with severe acroparesthesia. And when they were taking the usual medication, it was difficult for them to be good at school. Carbamazepine, Tegretol may induce some kind of somnolence. And I think that we succeeded treating early these 2 girls, I think, when they were 10 and 14. So it's not impossible to treat young patients, and either with enzyme replacement therapy or even with chaperone migalastat, and so that we have to make some paperwork to do that, but not only myself, but Michael West and people from Toronto and from the West and from the Magic Clinic are also sensitive to these early type of treatment in these patients. So I encourage that. I would like to just say something about, I'm concerned about depression and sometimes severe depression in male and female patients with Fabry disease, which seems to be more prevalent in Fabry disease as compared to other type of metabolic disease. If you have some patients, do not hesitate yourself or some nurses in their clinic to ask some question, how have been you going? I hope you are not depressed, so that I'm touching that almost at each type of visit. And we have a psychologist taking care of these Fabry male and female patients. And I think this is very much valuable. There's a lot of things that we do not know beyond the brain type of imaging, you know. There are billions of cells there, okay? Maybe not in every American president, but I'm sorry. Okay, good. Okay. Thank you.
Thank you. Any other questions? No questions?
I can say something. My English is not very good, but I will answer one of your question. Why we don't always talk about our symptom? It's because they don't have treatment. You know, like you said about how you call the two symptom, by example, the two symptom for the brain. Okay, yeah, you have dizziness and you have the other one, like shadow in your head. Okay.
Foggy brain.
Wait, foggy brain. I do have that. And since 2, 3 months, I have a very, very, very strong fatigue, which fall on my nerve because I'm usually a hyperactive woman. And it is, and you talk about depression. For me, is easy to fall in depression. It's very hard to keep your head up because you I have 65 and you look your life, you have to deal with this disease. And I how can say that? Can you help me, Dr. Bichet? Tu viens d'essayer de sortir d'un cancer. How
Yes.
you say?
Yeah, you know, Madame Saunier is saying, you know, there are complicated features in addition to Fabry. And for example, some patients may have to deal with cancer. And so that, you know, in infusions, cancer, investigations for cancer, how do Fabry disease impinge on, you know, your will to be operated on, to delay, to ask questions and things like that? So Madame Saunier is quite right. You know, it's not only difficult as far as Fabry disease signs and symptoms, but also it is difficult to some way, you know, be confronted with the difficulties of life, being, you know, personal difficulties, depression, but also additional features, difficult features like cancer. But with time and with a good clinic, and Carole Fortier is here, you know, I think we can do that. And sometimes, even when our Fabry patients are not fully decided to do something, we can wait, encourage them, and see exactly how, you know, we can go through these difficult times. Madame Saunier has an affected son who is doing extremely well. And so that, you know, you should think about these things too. That means that there have been some kind of progresses throughout the generations. And definitely, we hope that this will continue. And Madame Saunier is right, stating that there are a lot of things that physicians and scientists do not know. That's very true. We do not know exactly why there are so many, yeah, you know, complications and severe complications, and in patients, males and female patients with Fabry disease. Yes. Merci, Madame Saunier. So we have another question here. My daughter is 12 and so far does not present with any Fabry symptoms or manifestations. What are things my husband and I can look for at home in terms of changes in her? Yes. So, mais peut-être que Sheila and Rebecca, you could address this question. Why not, you know? So that then I can help you if you
Yeah.
need. But maybe you can start. Okay, why not?
Yeah, it is a great question. And the answer to that will probably vary a little bit from office to office, from practitioner to practitioner, because she's not symptomatic. And what we don't want to do is over medicalize young people that aren't showing symptoms. So Fabry disease is not her identity, is not who she is. And if there's no symptoms showing, that's amazing. So at 12, we're not going to do annual MRIs on a 12-year-old. If we do have some children around that age with Fabry disease who do come in annually, and we have a conversation and we do a check-in. We do check that lyso-Gb3 annually-ish when they come, just to get them used to the medical system. We don't expect symptoms in girls that young, but we if we're aware of them, we're going to track them. We want them to know. We want to teach these girls early how to advocate for themselves, and all the things that we just talked about when they have their eye exams. Does the eye doctor see that corneal verticillata? Have you noticed any hearing? Is she complaining of GI? It certainly could be present, but it also could be attributed to many other things that 12-year-old girls experience as well. So it is a balance with our kids, and I do think physician to physician has different approaches across the country.
I think it's important to keep the dialogue open though, right? Keep that conversation going with her. And if you need extra care, to reach out to your care team and ask for some visits to just chat with her. And specifically I'm thinking of our teenagers. Rebecca got to join the teen group up in Canmore, and just seeing the heat cold intolerances and what does that look like with neuropathic pain to your extremities. And that can be a real symptom that's very concerning for this age category. So I think just continue to monitor. What do you see? How is their quality of life impacted on a daily basis? And maybe we encourage our patients just to keep track in a journal or a calendar, because sometimes we hear symptoms from our kids, but we forget. And so it's helpful just to write those things down so that when you do get to those visits, you can say, hey, she's been impacted this many times in a week. She's missed this many days of school. And then we can look to see, is there any interventions we can do to help? I'll hand it over to you, Dr. Boucher.
But, you would agree with me that I'm not sure from the question whether she has been tested. And I have the impression that this is the mom who is speaking, and so that, and not the father. So to me, the father is non-affected, so that this is not an obligatory carrier.
Yes,
Oh,
she
she
is
was
tested.
tested. Fine. Okay, thank you. Very good.
And in a couple years, here's your plug. The CFA does an amazing youth connection opportunity every couple years, and we hope that will keep building. So that's a really cool initiative. She's on the young end for that still.
That she gets to learn who her people are. She gets to learn who's in her community and on her side, and that is so important. So yes, I encourage you to continue dialoguing with the CFA.
Thank you.
So
And
we
thank
have a
you, Amy, for
nervous
your question.
stomach. We have a nervous stomach from the question GC, okay? So Sheila and Rebecca, you are good at nervous stomach. Okay?
Okay, so for me,
I'm
sometimes
just teasing.
hindsight
I'm
is
just teasing
2020.
because
I'll just read the question. When I entered puberty many decades ago, I had a lot of GI issues, a lot of pain, got chalked up to a nervous stomach, and it was treated as such, thinking perhaps it's the onset of GI symptoms related to Fabry. You're not wrong. Like, as I mentioned, many women come to clinic and their number one symptom is GI pain, discomfort, whether that's diarrhea, constipation, inability to tolerate certain food choices. And I think it is complicated because of our female reproductive system and our cycle. And so often physicians can overlook sometimes the female GI symptoms. And I think just now it's gaining some more traction and getting some more attention. So yeah, we talked about some troubleshooting with that. You said not a question, more a comment to Amy. Yeah,
this is very important.
Something to watch for sure.
This is very important because, in fact, the patient that is coming every year to see me this morning, so she's a de novo mutation, so she has no history of Fabry disease. And her first symptoms were the symptoms that you described here, a lot of GI issues. And somebody in her family was a GI physician, and so that she had repeated gastroscopies, negative gastroscopies, and nothing was found up to the time that she had some cardiac arrhythmias, needed a pacemaker, and finally had some kind of possibility that she had Fabry disease. And indeed, she has a de novo mutation with Fabry disease, and she has been treated. So I believe very much not only from these patients, but also from other female patients that GI symptoms are quite annoying and could be, the first bad symptoms to pinpoint on Fabry disease. So we are extremely careful. The patient is doing well. And so that have been treated now more than 20 years. Carole Fortier was not here this morning, but I took care of her, so that of the patient. So that was good. Thank you for this question.
Thank you.
Thank you. Okay. Well, this has been wonderful. Thank you to everybody who has joined. And Sheila, Rebecca, Dr. Bichet, um, I'm sure everyone listening just feels like, whew, this feels really good to hear this from our healthcare teams. So that comes through the compassion and the willingness for us to then share the partnership, all of it. We're really lucky to have you all in Canada and working with us and doing all these great things. So thank you to all of you.
Thank you, Julia.
Julia.
Thank you, Julia.
Merci
We
beaucoup.
oh, go ahead.
No, I just said thank you, but in French.
Oh yes.
Sorry.
We will have another one. We're going to have a webinar part 2. I just want to say that real quick before I forget. Pulling up the date here, it's the 15th. Yeah. So April 15th, 7 p.m. Eastern Time, we're going to do part 2 of Fabry Females. So you don't want to miss that one. Share it with your community. And in the meantime, take good care. And everyone is saying thank you very much. So thank
Find
you.
your people.
Find your people.
Find your people.
Find your
And thank
people.
you for Amicus to organize all that.
Yes,
Thank you, Amicus.
Have a good night.
Thank you, Amicus. Take care.
Take care.
Bye, guys.
Bye.
Excellent presentation. Okay.